for this session. A warm welcome to all of you. I would like to request all of you that we'll be following in the same order as is given, except for the second one. We'll be calling Dr. Tanvi Gnatra second because she has a session soon after.
Good morning, myself Dr. Soumya. I will be also your chair for this session. Like we will be calling if all the persons are ready, okay?
Dr. Rajalakshmi S. Uh, is Dr. Rajalakshmi here? And can we have Dr. Tanvi also ready with her presentation? May I request if anybody has not uploaded their presentations to please kindly do so right now at the back desk. And if you want to check, you can please do that now. Uh, we will start with Dr. Tanvi then for lack of time.
Hello. Hello. Management of acute hydrops in keratoconus with ASOCT. Acute corneal hydrops, a severe complication known to occur in 3% keratoconic eyes, occurs due to a rupture of the Descemet's membrane, which is conventionally managed by patching bandits of contact lenses hypertonic sodium chloride solution. It usually resolves within 3 to 6 months. The non-invasive high-speed, high-resolution imaging modality ASOCT provides a detailed imaging of the cornea, anterior segment and angles. The purpose of our study is to monitor the progression of acute eye drops in a patient with bilateral keratoconus using ASOCT, which helped us navigate the appropriate treatment and manage the patient medically based on our findings. A 53-year-old male presented with complaints of redness, watering, pain, and diminution of vision in the right eye since 6 days. He denied any other positive history. The patient underwent various clinical testing and examinations, including the ASOCT. The BCVA in the right eye was finger count half meter and left eye was 6'9". The slit lamp evaluation revealed the presence of a localized area of excessive dense corneal edema with bullae with an associated corneal opacification suggestive of acute eye drops in the right eye. The ASOCT showed a severe corneal stromal edema with rupture of the Descemet's membrane and large intrastromal clefts. The patient was medically managed using loteprednol, Hypersol, Repatec, and Bremolol eye drop. Regular follow-ups were done at 1 week, 3 weeks, 1, 2, 3, and 4 months. On every visit, the visual acuity, central corneal thickness, thinnest pachymetry over the hydrop lesions, and ASOCT was done. As can be seen, the best corrected visual acuity went from finger count half meter to finger count 2 meters at the end of 4 months. The central corneal thickness went from 590 microns and finally reduced to 211 microns at the end of 4 months. The thickness at the site of eye drops also went from 915 microns at the start to 216 microns at the end of the 4-month follow-up. As can be seen from the slit lamp images, this shows a slow progressive decrease of the corneal edema and finally scarring at the 4-month follow-up. Similarly, the ASOCT images also shows initially an increase in the corneal thickness along with intrastromal clefts, finally leading to resolution of the edema and scarring. On regular and close follow-up of the patient, changes in the stroma and Descemet's were seen along with the decrease in corneal thickness using this ASOCT. Following the confirmation of the resolution of corneal edema by ASOCT, we gave a patient a trial of scleral contact lenses and the vision improved to 6'9". The differential diagnosis for eye drops includes keratoconus, keratoglobus, pellucid marginal degeneration, and others such as infectious keratitis, uveitis, etc. ASOCT is an ideal method to stage and document the corneal eye drops. to visualize the rupture in descemetes, the extent of detachment from the cornea, also in monitoring the resolution of edema, reattachment of DM, absence of DM, and scar formation. It also aids in serial corneal thickness measurements. Just the last slide. Therefore, we believe that in patients of keratoconus with acute hydrops, an ASOCT is an invaluable tool, not only in helping us establish diagnosis, but also in monitoring the resolution of corneal edema and establishing the end point of resolution, whereby corrective measures can be taken to improve the visual outcome in these cases. Thank you.
Thank you, Dr. Tanvi. Any questions from the audience?
We'll call, right now we will call Rajalakshmi, yes. She ready? Yeah. Can I start?
Yeah, you can please.
Good morning, everyone. I'm Dr. Rajalakshmi, Assistant Professor from JIPMA Karaikal. I'm presenting about a conjunctival inclusion cyst versus filtering bleb, a close mimic. Conjunctival inclusion cysts are benign conditions which can be acquired following trauma or after surgeries like strabismus surgery, pars plana vitrectomy, or even cataract surgery. I had a 60-year-old female who presented with foreign body sensation in her left eye, in which she had undergone cataract surgery 6 months ago. On examination, there is a 2 by 3 millimeter oval, transilluminant, vascular, smooth and raised, immobile cystic swelling at 1 o'clock position near the limbus, exactly on the site of the previous SICS tunnel. Differential diagnosis was a filtering bleb at that scleral incision. There was no fish mouthing of the wound on gonioscopy. However, for dearth of resources, we could not subject her to UBM or anterior segment OCT. Needling can cause recurrence, so we planned for a cyst wall cyst excision in the operation theatre. However, it got inadvertently ruptured at its basal attachment near the sclera, but there was no collapse of anterior chamber. She was not affordable for histopathology examination. The patient was, who had undergone the cyst excision was followed up for nearly 1 year without any recurrence. So conjunctival inclusion cyst can occur following SICS surgeries also, which is due to impaction of the conjunctival tissue at the scleral tunnel by dragging of conjunctiva while implanting IOL, etc. Filtering bleb is another differential diagnosis here, whose incidence rate is around 1 to 7.7% following cataract surgeries. It can be of two types, encysted or communicating. This can be prevented by construction of a well-sealed scleral tunnel incision and avoidance of excessive cautery at the scleral section. Also, meticulous conjunctival closure at the end of surgery will help a long way. There are several treatment options ranging from simple conjunctival cyst excision to trypan blue assisted cyst excision with or without autoconjunctival grafts. So I conclude that if we encounter with a conjunctival impaction cyst following cataract surgery, a filtering bleb has to be borne in mind. Cyst needling or aspiration can result in recurrence. Not only that, it can, suppose if we treat a filtering bleb using a cyst needling, it can invite endophthalmitis or even collapse of anterior chamber when we do it in the slit lamp in the OPD. Cyst excision is a definitive treatment for this procedure. Thank you.
While doing this procedure?
If we think it is a simple cyst and we do it, try to do it in the OPD only, there can be sudden collapse of anterior chamber. It can cause hypotony maculopathy also, and sudden loss of vision is a complication. And not only that, because of the opening created, it can invite organisms leading to endophthalmitis. So better to plan in the operation theatre and then decide on the treatment. Yes. So if it is a small loss of tissue, no need to place a graft. Otherwise, we would require a graft.
Will you suture the will you use a glue or do you suture it?
In this, my condition, I did not use a glue also, ma'am. It healed along with it. If it is a small area, we can just leave it also. And especially if it is a superior area, it allows to be closed by the lid. I had treated one more inferior fornical cyst also, that I had to suture. So it depends on the location also.
Thank you.
Thank you.
Dr. Harilal Naik. Dr. Anik Ghosh. Meanwhile, do we have Dr. Shri Divya here?
PPT is not here. Yes, I uploaded it. I had uploaded.
Can we call the next
Pen-
person while Dr. Anik Ghosh does the uploading?
I did upload it. You see Theater 1, Day 2. AIOC Theater 1, back jai.
Next person, Dr. Shri Divya.
May I start? Good morning, everyone. I would be presenting prevalence and severity of dry eye among medical students in West Bengal using the OSDI questionnaire. I have been guided by my head of the department, Dr. Vishwarup Rai, in this regard. As we know, dry eye is a multifactorial disease manifested by ocular symptoms in which tear film instability, hyperosmolarity, and inflammation play etiological role. It is influenced by various factors like geographical area and climate, but also in recent times due to exposure to air conditioners and excessive screen time. And the main point here is that eyes get fatigue even after reading for a short time. So it is likely to cause academic compromise in academic performance. In recent times, owing to increasing trend of online learning through video lectures via mobile or laptops, much screen time is expected among medical students. Also, in lecture classes, long exposure to air conditioners is seen. Furthermore, Bakura, the place where I am from, it has a hot and dry climate, which contributes and further necessitates the utility of this type of studies. It is a cross-sectional study based on previous prevalence and absolute error of 10%. I took a sample size of 92 and OSDI questionnaire were given out as it has a shorter completion time and easily comprehensible. And this is ideal for screening. It focuses into presences and frequency of specific symptoms and their impact on vision-related functioning. It has good to excellent reliability, validity, sensitivity, and specificity. Discussion. According to the OSDI grading, dry eye was seen in an alarming 41.3% of students. The severity was mild 25%, moderate almost 10%, and severe 5%. And usage of mobile or laptops are seen in almost half, 48.9% of students. Among those students, there was 46.7% of students who had dry eye, and it is a statistically significant association as the p value came less than 0.001%. So the conclusion here is the prevalence of dry eye among medical students was considerably high and likely to affect academic performance and quality of life. Indeed, our study shows increased prevalence and a significant association between dry eye and longer duration, that is more than 6 hours a day of mobile laptop usage. With increased use of gadgets, among the medicos, they are prone to develop dry eye, hence early diagnosis and treatment and general education of the medical students themselves are of paramount importance. The last slide this is. So the limitation can be that I use only the OSDI questionnaire. That can be considered as a limitation. But as the study was more focused on prevalence, we felt that OSDI questionnaire using was sufficient. There are no conflicts of interest here. References, I used these references and the Jamovi project for my statistical analysis. Thank you.
Thank you. I do have a question. Among the medical students, did you do the study in between which years or?
Yes, sir. I classified the students. I took from all the years some students. I took from the pre-final and the final years.
Okay.
Mostly they mostly contributed to my study. Also the second year ones
All right.
who are already using the apps like Marrow and Plebler that are available everywhere. So
Alright.
they are more, I thought they were more prone for developing these drier kind of symptoms.
And was it just before the exams, like 1 or 2 months before the exams, or it was random?
It was it was at the month of June. That means the semester exam, the last semester and the coming final year exams were coming though. So that time the usage was a little bit more.
Thank you. Thank you. Now
Welcome.
we'll have the next presenter, Dr. Shri Divya. Can I please request the other presenters to kindly check their PPTs if it's been uploaded?
Please, Aditi Pratap, should we?
Not uploaded. I have a pen drive.
Can I please request the presenters to check that their PPTs have been uploaded at the back desk?
Good morning to one and all present here. So I'm going to present a rare case on anterior ectopia cilia. So generally we know that the eyelashes, they grow along the edge of the eyelid and their function is to protect the eyes from the external environment. The upper eyelid contains around 100 to 160 lashes and the lower eyelid around 70 to 80. These lashes, they grow on an average of around 3 to 4 rows. Next. So this is a small anatomy of the eyelash. So ectopia cilia, it is also called an aberrant cilia, is a misplaced cilia, which is a rare condition where the eyelashes, they are found over an abnormal site, most commonly along the lateral quadrant of the anterior surface of the upper eyelid. So there are two types. There is an anterior and a posterior ectopia cilia. Anterior is generally congenital and posterior is an acquired type. So anterior ectopia cilia, they are seen along the upper quadrant of the upper eyelid, generally between the medial 2/3 and the lateral 1/3. So the embryological origin of these cilia, it is unknown, and meibomian gland substitution theory has been refuted in this case. So I report a case of an ectopia cilia. This is the 12th case report in the world. A 7-year-old boy who presented with complaints of a tuft of hair over the outer aspect of the right upper eyelid. There was no complaint of defective vision. Family history was of nil significance. General examination was normal. Ocular examination was normal. And generally a tuft of densely grouped hair was seen along the lateral aspect of the upper eyelid between the medial 2/3 and the lateral 1/3. So eversion of the lid had a normal palpebral and a bulbar conjunctiva. There was no other ocular abnormality. Extraocular movements were normal. Anterior segment was normal. Vision was 6/6, and the rest of the ocular examination was normal. MRI was done to rule out any dermoid cyst with the sinus tract, but MRI was also normal. So this is the case with an anterior ectopia cilia, around 8 mm away from the upper eyelid margin. It can be seen here. A tuft of around 20 to 21 hair was seen arising. The palpebral conjunctiva was normal. So surgical removal of the abnormal cilia associated with the hair follicle was performed. So after eversion of the affected eyelid, the follicle of the ectopia cilia was excised in en bloc along with a scalpel blade. So recurrence was not observed even after 3 months of the surgery. So that is the ectopia cilia that was removed and excised. So conclusion, it is a very rare congenital anomaly in which the eyelashes, they grow from an abnormal place, typically in the lateral quadrant, and it is generally rare in humans. Treatment is surgical excision. Thank you.
Thank you, Dr. Shri Divya. And you did it as an office procedure, as an OPD procedure?
Yes, sir. They came as an OPD patient. We posted them for the next day and we did the excision.
Any questions from the audience? Thank you, Dr. Shri Divya. Can we have the next presenter, Dr. Aditi Parab?
Next, Vivia, be ready. Okay.
So, good morning to all. My topic for today's presentation is effectiveness of screening criteria in diagnosing keratoconus among children. So, the purpose was to analyze the positivity rate of existing screening criteria, which included mean keratometry of more than 47 diopters, positive family history, and abnormal corneal topography in diagnosing keratoconus among children aged less than 14 years. It's not moving, sir. I'm pressing, it's not. So, it was a retrospective study which included children below 14 years of age with a positive sibling history of keratoconus and diagnosis of keratoconus suspects along with vernal keratoconjunctivitis. So, among the study population, we had 59.7% males and 40.3% females, out of which 55.2% of males had keratoconus and 44.8% had females had keratoconus. Coming to the results, the 4.5% of keratoconus patients had a positive sibling history of keratoconus, which was found to be 3 times higher than that of the study population, and there was a significant association of positive sibling history with both the groups. Vernal keratoconjunctivitis was found to be 11.9% in the keratoconus group. Again, this had a significant association with both the groups. History of eye rubbing was present in 20.9% in the keratoconus group. Simple myopic astigmatism was the most common refractive error among the normal as well as the keratoconus group, followed by the compound myopic astigmatism. Among the normal population, the 58.5% had keratometric readings of less than 45 diopters, whereas in the keratoconus group, 55.6% had more than 47 diopters keratometric readings. We were able to diagnose early keratoconus in 49 eyes, moderate keratoconus in 32 eyes, and advanced keratoconus in 16 eyes with the help of the screening criteria on the basis of topography. And as we all know, and it is already established that a positive family history of keratoconus, presence of ocular allergy, and increased eye rubbing are associated significant risk factors for the progression of keratoconus. So to conclude, the present screening criteria was able to identify abnormal topography in around 23% of the children. Precise screening criteria and tools would be of great value in the present era, as there is a significant increase in incidence of keratoconus diagnosis. So children with high astigmatism, positive sibling history of keratoconus and vernal keratoconjunctivitis should be screened for early detection and timely intervention to stop the progression of keratoconus. Thank you.
Dr. Vivian Nagdev.
It's not getting projected. Good morning. I'm Dr. Vivian Nagdev. I'm presenting a poster on custard apple seed powder induced keratitis, a not so fruitful traditional practice. Keratitis is the inflammation of cornea, a common ocular condition that can be caused by various factors like infection, trauma, or underlying diseases. Some cases of keratitis may be linked to less common causes such as the use of unconventional remedies or products. Here we see a case of keratitis induced by custard apple seed powder, a product that has been used in traditional medicine for treatment of lice. A 13-year-old female patient, she came to the emergency room of the hospital with complaints of severe burning, pricking sensation, watering, and intolerance to light in both her eyes. She gave us a history of application of custard apple seed powder to the head for treatment on lice. After giving a thorough wash of the scalp with water, she started experiencing irritation in both her eyes. On examination of the patient, we see mild upper lid and lower lid edema in both the eyes with associated congestion. Unaided visual acuity was 6.9 improvement to 6.6 on pinhole in the right eye, and left eye showed us 612 parts unaided and no improvement was seen on pinhole. Slit lamp examination, we see anterior chamber is of normal depth and quiet, and pupil and lens, no pathology was noted. In the right eye, we see punctate epithelial defect, while left eye shows an epithelial defect of 8 mm into 6 mm on fluorescent stain. Normal saline wash was given to the patient, followed by application of antibiotic eye ointment. Eyes were patched for the night and reviewed the following day in the OPD. On fluorescent stain, as we see in the following day, the epithelial defect is completely healed in the right eye and reduced in the left eye. Treatment received by the patient started on moxifloxacin eye drops, that is 0.5%, and CMC 0.5%, along with eye ointment tobramycin, that is 0.3% for nighttime application. Day 3, we can see completely healed epithelial defect in both the eyes, and patient was as well symptomatically better. Discussion, we can see custard apple is a commonly consumed fruit in India, but apart from the pulp of the fruit, the seeds and the leaf of the plant have also been used for treatment of different diseases. Extract from the leaves are used as anti-diabetic, antidepressant, and antimicrobial, and the seed powder is used for killing head lice as well as for skin exfoliation. The plant extract contains terpenoids, glycoside, alkaloid, flavonoid saponin, along with phenolic compounds and acetogenins. On contact with eyes, it can have severe side effects like toxic keratitis. For management, it is important for discontinuation of exposure to the components, giving a thorough wash, and starting topical antibiotics as well as lubricants. To conclude, as a take-home message, it is not a commonly reported case, but it can be noted in regions where traditional use of custard apple plant are still in practice. While it may offer potential health benefits, we need to keep in mind about the possible ocular side effects. It is important to take a detailed history when diagnosing patients with unexplained keratitis symptoms. Aggressive treatment with timely follow-up is vital for the maintenance of corneal integrity. These are my references. Thank you.
Thank you. So what did you consider giving ointment other than antibiotic ointment, HPMC ointment?
No, we had actually given ointment followed by which we had patched the patient for the night to follow up in the OPD next day, so that we can assess the treatment progression ahead if we need to start any topical fortified eye drops as well. So it was reviewed immediately the next day morning.
How about vitamin C and?
None of that was given, only topical treatment was given to the patient.
Any questions from the audience? Thank you. Moving on to the next presenter, do we have Dr. Markandeya Singh? Can I please request the next presenter to be ready? Akanksha Sinha. Please check your slides also.
Good morning. I'm Dr. Markandeya Singh. I will be presenting a case of keratoconus and bilateral congenital cataract in a patient with Down syndrome. A 14-year-old male patient presented with blurring of vision and diminution of vision in both the eyes, and the diminution of vision was present since birth and was painless and progressive. And the patient was a diagnosed case of Down syndrome, that is trisomy 21. Upon examination, the forehead, eyebrow in both the eyes were within normal limit. Eyelid in both the eyes shows epicanthal folds, and the eyeball were within normal limit. Palpebral aperture showed upward slanting fissures, and extraocular movement in both the eyes was normal. Conjunctiva in the left eye was dry, and the cornea in the left eye showed protrusion and thinning in a cone configuration with thinning maximal at the apex. Pupil in both the eyes was round, regular, and reactive to light. However, the anterior chamber in the left eye was deep. The lens in both the eyes were cataractous, and visual acuity in both the eyes was hand movement close to face. And upon examining the fundus, fundal glow could not be seen, and the fundus could not be visualized. Upon further examination, the Munson sign was positive in the left eye, and scissoring reflex was seen in streak retinoscopy. Slit lamp examination of the right eye showed mature cataract, while in the left eye we could see protrusion and thinning of the cornea with thinning maximal at the apex. Multiple superficial punctate keratitis were also noted in the left eye, and the left eye had deep anterior chamber and mature cataract. Excuse me. Here we can see three images. The first one is a slit lamp image showing the protrusion and thinning of cornea. The second image we can see multiple SPKs, and the third image shows the positive Munson sign. USG B scan showed cataractous changes in both the eyes, and keratometry values were suggestive of keratoconus in the left eye. Here we can see the ASOCT. The left eye shows thinning of the and ectatic condition of the cornea, and therefore my diagnosis concluded to be bilateral congenital cataract and keratoconus in the left eye. The patient was initially managed conservatively using carboxymethyl cellulose eye drops, and the patient was advised for cataract removal with IOL implantation in the right eye. However, even after proper counseling for the surgery, the patient's guardians were elected for the surgery, and the patient was lost to follow-up. Keratoconus is characterized by a central or paracentral corneal stromal thinning, apical protrusion, and irregular astigmatism. On the basis of keratometry, it can be graded as mild, moderate, and severe. And keratoconus can be seen in up to 5 to 30% patients with Down syndrome. However, the etiology is not clear, and frequent eye rubbing in Down syndrome patients may be a causative factor. And relative risk of congenital cataract is up to 300 times higher in infants with Down syndrome, which may be attributed to increased reactive oxygen species and aggregation of amyloid beta protein in the lens. In our case, the patient presented with keratoconus in left eye and cataract in both eyes, and such can be seen in syndromes such as Down syndrome, Leber's congenital amaurosis, and satisfactory treatment could not be achieved since the patient denied surgery, and these conditions may coexist, but they require the separate treatments. Thank you.
Thank you. Thank you. Uh, uh, were you able to grade the cataract and
Sir,
explain?
actually,
Yes.
it was actually mature cataract, sir.
Yes.
So,
Okay.
great.
And so in both eyes there was mature
Yes, sir.
cataract. So it was the visual rehabilitation was necessary, but
It
still
was necessary, but the patient guardians were reluctant because the patient had Down syndrome, so they were like hesitant because of that. Because we had to do under GA, and when we told them about that, we will have to put him under GA, and intubation will have to be done. Then they got a bit scared after listening to all that, so they refused for the same.
Okay. So counseling was done.
Yes, sir. Proper counseling was done. We admitted the patient for 1 week throughout. We did the investigations and explained to him about everything, but the parents finally refused.
Thank you.
Welcome,
Any
sir.
questions from the audience? We'll move on to the next person, next presenter, Dr. Akanksha Sinha. Do we have Dr. Rohit Dureja here? Next person, next speaker, please be ready.
This is not the one. This is not the one. I have uploaded my presentation. Catastrophic effects. I have Akanksha. You have, but this is not the one. This is not the one. Included my you have included my PPT in others.
Can we have the next speaker? Meanwhile, Dr. Rohit Dureja, Dr. Debasmita Bera. Can you please ask them first to upload? It's uploaded. Please tell them and then. Yes.
Yeah, good morning everyone. Myself Dr. Debasmita Bera. I shall be presenting a review of clinical microbiological profile and treatment outcome of infectious scleritis in Eastern India. I have no financial interest. Scleritis is an inflammatory disorder of the sclera. It is often due to immunological phenomena. 40 to 50% suffer from the systemic collagen vascular diseases. Infection, though rare but important cause of scleritis, occurring in 5 to 10% of patients. Infectious scleritis can follow trauma, surgery, or can occur as an extension of primary corneal infection. Variety of organism has been identified as a cause of infectious scleritis. Pseudomonas aeruginosa is the most common causative agents in various studies. Previously, clinical outcomes were reported to be poor and most cases require enucleation and evisceration. Recent reports suggest infectious scleritis can be managed successfully with preservation of vision with combined antibiotic therapy and early surgical intervention. This is a retrospective study. 42 patients were clinically diagnosed infectious scleritis has been included. The duration was from 2018 to 2023. Inclusion criteria: single or multiple scleral nodules with pus point, smear positive and culture negative cases, and smear positive cases were included. Total of 9 months of follow-up has been done. Any non-necrotizing scleritis has been excluded. Complete ophthalmological examination has been done. This include base-corrected visual acuity, slit lamp examination, intraocular pressure, dilated fundus examination with indirect ophthalmoscopy. Slit lamp photography, microbiological workup, and scleral scraping for the active lesions, immunological workup to rule out non-necrotizing scleritis, and associated B-scan, ASOCT, and UVN has been done. Clinically, here we can see picture A shows localized nodules with yellowish appearance, and picture B shows the multiple small nodules in cases of bacterial scleritis. A and B are the cases of the bacterial scleritis where we can see multiple nodules with the corneal infiltrates. This is a case of showing the scleral necrosis with uveal prolapse in case of post pterygium surgery. 1 month after post pterygium surgery, immediate scleral patch graft has been done. Due to inadequate vascularization, patient develops scleral patch graft melt, and finally, ultimately, the eyes has to be eviscerated. So, out of 42 patients, 24 were male and 18 were female, and 14 eyes were right and left. The age were between 20 to 82 years. In my case, Pseudomonas is also the most common bacterial organism found. So, we basically initially treated all the patients with broad spectrum topical antibiotics and treated as modified as per microbiological reports and culture sensitivity patterns. Microbiologically negative cases are also being treated with topical antibiotics. 10 cases underwent scleral patch graft debridement, additional 7 cases eyes with amniotic membrane transplantation. Overall treatment outcome was favorable in my case, resolving in 36% in 42 eyes. 2 cases were lost to follow-up, and 1 eye developed phthisis. 2 to 3 eyes need to be eviscerated. So in my case, microbiologically positive cases were more bacteria, more than fungus, more than mixed. And predisposing factor, trauma is the most common predisposing factor, followed by surgery. Early diagnosis and appropriate therapy is favorable prognosis. Surgical management in cases not responding to medical therapy. Recurrences are common, so long-term follow-up is required. These are my references. Thank you.
Thank you. About the patient with the post-pterygium patient with scleral,
Real prolapse
yes,
and scleral
prolapse.
necrosis.
You attempted a scleral patch
Patch
graft.
graft.
Can you just tell us what has happened after that?
Due to inadequate, it was a case of Aspergillus fumigatus. So the inadequate vascularization, the patient ultimately develops scleral patch graft meant, and ultimately the eyes needed to be eviscerated.
Any questions? Thank you. We'll move on to the next person. Next speaker, Dr. Parul. Yes, Dr. Akanksha. Do we have Dr. Parul here? Yes, please. Can I please request the next presenter to be ready?
It's open. Good morning, all. My topic is catastrophic effects of steroid misuse in viral conjunctivitis. So, the basic a recent outbreak of conjunctivitis in regions of Bihar came with complaints of redness, itching, and watering. It was usually self-limiting, but presented with severe symptoms even. And the use of topical steroid was mostly seen in most of the patient. So the purpose of my study was to examine the outcomes of steroid use in patients with presumed viral conjunctivitis and its complications. So it was a prospective study done in 3 months in AIOC2024, included patients with clinically diagnosed keratitis with history of steroid use for presumed viral conjunctivitis. Detailed history, clinical evaluation, posterior segment examination, and microbiological laboratory analysis was done. Treatment was advised accordingly, and regular follow-ups were done. So we included patients of all age group with positive history of viral conjunctivitis and steroid use, and excluded patients without history of viral conjunctivitis with history of other ocular surface disorders. So we extracted the results with 15 patients in mean age group of 34 years with male predominance and unilateral in most of the cases coming from rural regions of Bihar. Positive history of trauma and topical steroid use was present, with dexamethasone being the most commonly used agent available in most of the chemist shops, and the duration symptom was 6 to 15. This is a chart showing the number of patients and the result, which showed that positive history of trauma and systemic illness was present with the simultaneous use of antibiotics. So the best character visual acuity was 6/18 to PL negative, and size of ulcer was 7 mm, and half of the cases were presented with corneal perforation needing surgical intervention. And the most common organism extracted was fungal pathogen, and among them the Aspergillus was the most common, and others included MR cons. And medical and surgical treatment was given accordingly. Here are some of the pictures of my cases, which shows sloughing corneal ulcer mostly. So why do steroids lead to such catastrophic effects? By a study by Wong et al. Showed that the side effects of topical steroid leads to promotion of viral replication, leading to more progressive and more complications. There are many factors related to steroid that leads to such progressive course. So trauma being the most precipitating and the systemic illness being the most common coexisting factors with these cases leads us to think about this. The limitation of this study was absence of DNA PCR and cell culture in my study, which lacks to rule out viral infections, and sensitivity medications were also not performed. So finally concluding, I would like to focus on this point that we as clinicians should emphasize on the fact that use of steroids should be with proper guidelines, and judicious use should be done. That's all. Thank you. These are my references.
For the treatment with steroids of viral conjunctivitis, you said that they were using dexamethasone eye drops. Are there any other steroids that you would probably want to use?
The second most common use was the prednisolone. That was most commonly seen in 2 to 3 patients, and mostly dexamethasone because it is easily available as combination with antibiotics. So most of them were using antibiotic combination drops.
Yes. So probably that is not the best thing to do. Use combination drops. You need to use antibiotics separately, and if you're giving steroid drops, that also separately. So
We should
because of the, you can taper the steroids.
Yeah. Proper
Yes.
guidelines should be provided to patient.
And dexamethasone is probably not the best choice. Fluoromethalone is something that.
Low dose steroid is most probably we should start first,
Yes.
then we will follow.
Yes, because dexamethasone is more potent.
Yeah.
So the take-home message would be not to start with dexamethasone, but to start with something low potent like fluoromethalone, and to give separate.
Not prescribed combination
not
drugs.
prescribed combination drugs. Do we have any questions from the audience? Well, thank you.
Thank you.
Next up, do we have Dr. Parul Mittal? Dr. Prince Abu Amr? Can I please request the next speaker to be ready and to check the slides at the back desk? Dr. Deeksha Kumari, thank you.
Good morning, everyone. I am Dr. Prince from UCMS Delhi, and I am here to present topical insulin for the treatment of non-healing corneal ulcer. So what happened was a 51-year-old South Asian male farmer presented to our OPD with a complaint of redness and mild pain in the left eye since 1 month. There is history of exposure of left eye to the farming urea 1 day before the symptoms started. So the patient had only mild complaints, so he was pretty much very comfortable for 1 month. That is why he was just putting moxifloxacin eye drops too early, which he took over the counter and did not seek any emergency treatment. There is history of similar illness in the left eye 5 years ago following trauma by a rice bran, for which patient took topical treatment over the counter. And there is history of left facial palsy since childhood after an ear infection. There is no history of chronic illness. Right eye ocular examination was within normal limits. We come to the left eye ocular examination. The vision was finger counting at 3 meter with PR accurate. There is no improvement on pinhole. Extraocular movements were full and free. Facial asymmetry was present. There was meibomitis, lag of thalamus, but the Bell's phenomenon was good. In conjunctiva, there was diffuse and circumcorneal congestion, and corneal examination, we can see there is 5 into 4 mm epithelial defect with punctate epithelial erosions, with feathery margins and infiltration, with satellite lesions. Circumcorneal congestion can be seen, and corneal facet can be seen, which is the evidence of previous infection. There is hypopion in the AC and 4+ cells in the AC. On investigation, the routine workup of the patient was absolutely normal. The hemogram was normal. LFT, KFT, blood sugars, viral markers, VDRL, chest X-ray, ultrasound, whole abdomen, everything was normal. But what is important here is that despite having 4+ cells and hypopion in the AC, the posterior segment was completely normal. The ultrasound B scan showed only vitreous degeneration with posterior vitreous detachment. On microscopy, gram stain was negative, KOH stain showed fungal hyphae, but the bacterial and fungal culture of corneal scrapings both were seen negative. Maybe that was because of lab error or clinical error. We started the patient on broad spectrum antifungals and antibiotics along with cycloplegics, lubricants, and oral doxycycline was started for blepharitis. Despite all this treatment for 1 month, there was no decrease in the size of epithelial defect, although there was decrease in the size of infiltration and hypopion. So in view of the epithelial defect, we did temporary lateral tarsorrhaphy, but it was released 5 days after because the patient was non-compliant and he was very much uncomfortable. Along with that, we started topical insulin 25 international units per ml 6 times per day, along with tapered previous topical medications. So how did we prepare insulin? This 40 international units per ml is available in our setup. So we took 6.25 ml of this insulin, along with 3.75 ml of distilled water to get 25 international units per ml. We can see within 3 days, there was a reduction in the infiltration and reduction in the epithelial defect, which reduced more after 1 week of the treatment, as you can see in this image. This is the image after 2 weeks of insulin. You can see epithelial defect is completely healed, although there are some punctate epithelial erosions. The anterior chamber reaction is cleared, superficial and deep vascularization can be seen. Surrounding haze is reduced, and the opacification of ulcer has started. This is the follow-up after 2 weeks. The vision was 6/60. Lag of thalamus with Bell's phenomenon was present, so we still advise patient with lubricating eye drops and eyelid taping at night. And the patient is being planned for penetrating keratoplasty. Now, topical insulin has been used in the literature past, but it basically used for neurotrophic ulcers. It was used in concentration 25 international units per ml, 1 international units per ml, and for diabetic ulcers, it was basically higher concentration, that is 50 international units per ml, 25 international units per ml were used. So what is the mechanism behind that? It is believed to have receptors, insulin receptors are believed to be present on the cornea and lacrimal gland, which contribute to corneal wound healing, and there is increased cell migration and better adhesion of epithelial cells to extracellular matrix when exposed to insulin. There were no adverse effects when noted. No adverse effects were noted with the use of topical insulin at concentrations up to 100 international per units in any of the published cases. So in conclusion, topical insulin may be a simple effective treatment for non-healing corneal ulcers. Insulin like growth factor 1 with substance P has been shown to be an important modulator of corneal wound healing. Treating predisposing conditions like blepharitis is very important, and exposure of the cornea, such as in leg of thalamus, should be managed properly, because as long as the cornea is exposed, we won't be able to heal the epithelial defect. These are my references. Thank you so much.
Thank you. So while you were treating the patient with topical insulin drops, were the other drops also being given? And what were the other? Was it a bacterial? I mean, how would you actually go
Yes,
about if
sir.
it's
Actually,
bacterial or fungal?
symptomatically, the patient presented like a fungal corneal ulcer. They were very mild symptoms, and most of them were signs. But KOH was positive for fungal hyphae, but culture could not be positive for any, not for the bacteria, not for fungal. So we started the patient on broad spectrum antifungals and antibiotics, and even after 1 month, there was no improvement seen. But as soon as we started insulin, the infiltration, epithelial defect, everything reduced. So we tapered the medications along with 2 weeks of insulin that we gave. And then we tapered the insulin also for 1 week. So in total, 3 weeks of insulin was given. For 2 weeks, we gave 6 times per day, and then for 1 week, it was tapered.
And how was the patient on follow-up? Have you been able to follow?
Yes, sir. Yes, sir. The opacity has developed in patient. Everything is clear. Anterior chamber is clear, and he is being planned for optical penetrating keratoplasty. And not only this, sir, we have replicated this result in 5 other patients. One was viral keratitis, 2 were diabetic keratitis, and 2 were fungal keratitis.
So this patient, was there any other systemic illnesses?
No, sir. There was no systemic illness.
No history of diabetes
No,
also.
sir.
How do you prepare it actually?
Ma'am, 40 international units per ml is available in our setup. So we diluted, we took 6.25 ml of that insulin, and we diluted it with 3.75 ml of distilled water under absolute aseptic conditions, and then we refrigerate it for 3 to 4 days. We don't use it for more than 3 to 4 days. We change after every 4 days.
Thank you.
Thank you, sir. Thank you, ma'am.
Over to the next speaker, Dr. Deeksha Kumari. May I please request the other next speaker also to be ready, Dr. Tripti Sute. Is Dr. Tripti here?
Good morning, everyone. Today I'll be presenting on the topic of comparison of different techniques used in attachment of conjunctival autograft in pterygium excision surgery. So pterygium is a wing-shaped fibrovascular overgrowth arising from subconjunctival tissue extending across the limbus onto the cornea. This is a degenerative condition of the subconjunctival tissue which proliferates as a vascularized granulation tissue to invade the cornea and the layers like stroma and Bowman's membrane. It is managed conservatively. Surgery is to be done only in selected cases having higher grades of pterygium. Today, the most common surgery done using conjunctival autograft to cover the bare sclera after pterygium excision. This graft can be stuck with different means. In our comparison study, 30 patients were taken and divided into 3 groups of 10 patients each in fibrin glue, sutures, autologous blood. Conjunctival autograft was first described by Kenyan et al. In 1985. It involves removal of limbal tissue and adjacent conjunctiva from another part, mostly superiotemporal, of the same eye to cover the bare sclera. It gives good cosmetic result and low recurrence rate. This image is showing harvesting of autograft. This is image showing steps of the surgery in which head of the pterygium excision done, dissection of subconjunctival tissue done, and harvesting the graft from superiotemporal region area and place it. In group 1, fibrin glue was used to attach the autograft, which was prepared from Tissel kit. By mixing the 2 components, solutions were prepared and drawn into different syringes. 2 to 3 drops were placed on the scleral blood and autograft were flipped over the bare sclera. In group 2, we used polyglactin absorbable sutures to secure the graft. In group 3, a thin film of blood which is invariably present over the bare sclera is used to place the graft, and edges were held with the forceps for 3 to 5 minutes and graft gets so that it gets fixed. So the results are surgical time for group 1 was 30 minutes, for group was 60, and group 3 is 40 minutes. Pain and foreign body sensations were present in all cases of the both the group 2 and 3, that is with blood and suture, and recovered after 2 to 3 weeks. In group 1, the symptoms were present in few cases and were asymptomatic after 1 week. All the patients were evaluated for signs of recurrence of pterygium, and it was noted in group 2, that is with suture, and group 3 blood after 3 months of post-operative period. At the end of final follow-up of 6 months, no recurrence was seen in group 1, that is with fibrin glue. So the conclusion is Fibrin glue and autologous blood both are good alternatives to the sutures in attaching conjunctival autograft in pterygium surgery. And the use of this both shortens the operating time and produces less post-operative discomfort. The only disadvantage with fibrin glue is its high cost. However, one vial can be used for multiple patients. Thank you.
Have you encountered any adverse effects with fibrin glue, any kind of allergic reactions in these patients? No.
sir.
All right, thank you.
Thank you.
Any questions from the audience? We'll move on to the next speaker.
Tripti. Shilpa, be ready, okay?
Good morning, everyone. Myself, Dr. Tripti Sutte. My co-authors are Dr. Kavita Dhabade and Ishan Varzukar, sir. My topic is outcome after optical keratoplasty in congenital hereditary endothelial dystrophy, the siblings curse. Congenital hereditary endothelial dystrophy presents in the perinatal period. Autosomal recessive mutation affecting the corneal endothelium on gene SLC4A11 chromosome 20p13. SLC4A11 codes for transmembrane protein, which is bicarbonate transporter related protein, that is BTR1. It acts on corneal endothelium. On mutation, there will be abnormal secretion of endothelium, which causes stromal edema, disruption of collagen fibrils, thickening of the Descemet's membrane, which eventually leads to corneal opacification. In our case, there was 3 siblings. Amongst them, I'm presenting one of them, that is 24-year-old male patient brought by his father with chief complaint of whitish opacity in both eyes since childhood, complaint of diminution of vision in both eyes and hearing loss in both ears. My pedigree chart shows the father and mother who had 6 children. Amongst them, 3 were deceased. Among the 3, 2 were males and 1 was female. The one I have put the arrow on is the one I'm presenting the case of. On ocular examination, vision of both the eyes was finger counting close to face, PR accurate. In cornea, it was bluish gray ground glass appearance with total corneal opacity with corneal edema with nystagmus with rest details not commentable. On diagnosis, both the eyes, congenital hereditary endothelial dystrophy with Harboyan syndrome in all 3 siblings. On B scan, both eyes had vitreous degeneration. Plan of treatment, optical penetrating keratoplasty along with cataracts done in same setting. Other eye was operated 2 years later. Graft failure secondary to graft rejection was noted after 1 year. In right eye, 6/60 was improving to 6/18 and left eye finger counting close to face. PR accurate. The donor graft of right eye was clear. The host was leukomatous and graft host junction was well opposed. The left eye, graft failure secondary to graft rejection, so rest details were not commentable. Mean age of 23 to 26 years of age at the time of surgery of both the eyes at an interval of 2 years was the surgery was done of the other eye. Penetrating optical keratoplasty was done in all the 3 siblings of both the eyes. One showed the clear graft and other showed the graft rejection. In conclusion, penetrating optical keratoplasty is safe and successful procedure in children with an acceptable graft survival in a mid-term follow-up period. Conclusion, chances of graft failure can occur in later period. Optical keratoplasty is a definitive treatment which can produce substantial visual gain. Thank you.
Of graft failure, can you tell us what probably was the reason for that?
The patient came at the age of 23 years. The patient had CHED along with nystagmus. The nystagmus at an early age, if it starts, then it can lead to graft rejection. Due to graft rejection, there was graft failure in one eye, and there was also post-op complications that led to graft rejection.
How much vision these patients have right now?
6/18 of one eye and other had failure, so yeah. Thank you.
Dr. Shilpa K.
Myself, Dr. Shilpa. I am presenting a case of microsporidial keratitis. Microsporidia are unicellular obligate spore-forming intracellular eukaryotes which are closely linked to fungi. They are opportunistic pathogens which causes infections of intestine, eyes, sinuses, lungs, muscles, kidneys and central nervous system. Ocular manifestation is the second most common following intestinal manifestation. It is caused in immunocompromised patient, contact lens wearers, trauma prior to refractive surgery, exposed to contaminated water. It accounts for 0.4% of cases of microbial keratitis. Case, a 26-year-old male patient presented with the complaints of redness and discharge from both eyes since 4 days. Patient also had fever and cough since 4 days. There was no history of trauma or contact with contaminated water. On examination, the visual acuity was 6/9 in both eyes. On slit lamp examination, we can see diffuse circumcorneal congestion and multiple white subepithelial lesion with stuck-on appearance on both the corneas. The underlying stroma and endothelium were normal. No anterior chamber reaction noted. This is the fluorescent stained picture showing greenish infiltrate over the cornea under the cobalt blue light in both the corneas. Treatment was given 0.5 moxifloxacin eye drops and 0.5% carboxymethyl cellulose eye drops hourly. Antipyretics and cough suppressants were given. Complete blood count were within normal limit and viral markers were negative. Patient improved after 5 days. The white subepithelial infiltrate reduced after 5 days on applying antibiotics and lubricating drops. Discussion, microsporidia are seen in humid environment of tropical region. The exact route of microsporidial infection is not known. It may be caused by contaminated water, ocular trauma or contact lens use. Microbiological diagnosis can be made by corneal scraping. Gram stain show gram-positive microsporidial spores in the epithelium. Fluoroquinolone monotherapy showed good response. Conclusion, microsporidial keratitis is a rare cause of keratitis. It usually resolves without any sequelae or any residual effect, but if not treated adequately, subepithelial infiltrate can lead to subepithelial scar and can cause limbitis and keratic precipitate. Fluoroquinolone shows good result. Topical steroids are indicated in non-responsive patients with persistent subepithelial infiltrate and uveitis. These are my references. Thank you.
Thank you. We'll go on to the next speaker, Dr. Srimeya Palanisamy.
Good morning. Today my talk is about role of accelerated corneal collagen cross-linking with photoactivated chromophore in infectious keratitis. Actually, riboflavin when exposed to UV light get activated and it inhibits it creates a crosslinks in the corneal stroma. Why this study? Recently, a growing number of studies suggest that collagen cross-linking has been proposed as a therapeutic option in handling infectious keratitis due to favorable effect on the block of corneal melting along with antimicrobial properties of photoactivated riboflavin. Most of the studies uses Dresden protocol, which is 30 minutes at 3 milliwatts per square centimeter. In this study, we tested whether collagen cross-linking for infectious keratitis can be accelerated according to the Bunsen-Roscoe law of reciprocity to 10 minutes at 9 milliwatts per square centimeter. Major reviews and RCTs done at Arvind Eye Care System suggest careful modifications of treatment parameters such as irradiation, duration, type of chromophore and fluence used might help increase the microbicidal efficiency of PAC-CXL. Our study design is an interventional cohort study, and our population is the all microbial keratitis patients refractory after 5 days of standard medical management, and the intervention is accelerated C3R. The outcome of the trial was resolution and size of the ulcer and prevention of adverse events including perforation. Time period is August 2023 to November 2023. On the first day of presentation, the patient has been treated with standard medical management. And on the 5th day, if the ulcer is resolving, we continue the standard medical management. If it is refractory, the patient has been subjected to accelerated C3R, and the outcome was measured at 3 weeks and 3 months. Under inclusion criteria, microbial keratitis refractory to medical management after 5 days, ulcer size up to diameter of 8 mm, with or without hypopyon, and ulcer not involving limbus. Exclusion criteria, any previous history of herpetic keratitis or parasitic keratitis, autoimmune diseases, and endophthalmitis. Methodology, the procedure has been done under sterile conditions in an operating room setting. After installing topical anesthesia, the cornea was treated with 0.1% riboflavin and exposed to UVA light for 10 minutes at 9 milliwatts per square centimeter. After Paxlovid, standard antimicrobial treatment was continued. Complete healing is described as the resolution of eventual hypopyon and reepithelialization of the corneal epithelial defect and stromal scarring, whereas treatment failure is defined as non-resolving, extending to limbus, and perforation. Our results, out of 16 eyes, 8 were men and 8 were women with the median age of 55 years with the mean ulcer diameter of 4.5 mm. Hypopyon was present in 15 out of 16 cases with the organisms include 12 cases of fungal keratitis, 1 case of bacterial keratitis, and 3 cases remain culture negative. Of this, 7 cases healed shows complete healing with scar, and 1 case underwent perforation, and 8 cases underwent TPK. From this, we conclude there is no benefit of adjuvant accelerated collagen cross-linking in the treatment of microbial keratitis, and there is no increase in percentage epithelialization at 3 weeks or 3 months, and there is no difference in adverse events including corneal perforation and need for TPK. Coming to the discussion, riboflavin and UVA both possess antimicrobial activity. Riboflavin, on exposure to UV light, gets activated into riboflavin triplet state. It can enter either into aerobic or anaerobic mechanism, by which it causes formation of covalent crosslinks and results in corneal strengthening. The strength of the study, it is easy to conduct because it is a prospective cohort study, it is cost effective, it is feasible for secondary eye care centers, and our methodology is akin to real world practice except for C3R, and we are processed strict adherence to the protocol. The limitations, sample size is small and it is a cohort study. Under study methodology, we do not have access to AIOC, and it is a single center study and it is not masked. What did the study adds? The strength of the meta-analysis or multi-centered analysis of similar small cohorts may produce results equivalent to or more than that of randomized control trial. The limitations should not discourage smaller eye care centers from conducting such studies.
Dr. Shrime, I would like you to wind up, please.
Yes.
Exceeded your time.
Thank you.
Thank you. Can I call the next presenter, Dr. Shreyashi Tripathi?
Good morning, everyone. I am going to present my poster on the topic Clinical Evaluation of Cornea Affected in Systemic Diseases, Their Current and Emerging Treatment. I am guided by my professor in HOD, Dr. Parvez Ahmed Siddiqui. Introduction. Cornea is an integral part of the body and reacts to various diseases or genetic abnormality at the systemic level. Corneal epithelium plays an important, crucial role in maintaining ocular surface homeostasis and is an important barrier to pathogen and environmental agents. These insults may be infectious agents, metabolic disorders, autoimmune diseases, or heritable changes in gene expressions. Study design was prospective observational study. Study sample was 60 eyes. Study area was upgraded Department of Ophthalmology, NSCB Medical College, Jabalpur. Demographic details, relevant history, best corrected visual acuity, and complete ophthalmological examination details were recorded. All the patients having systemic illness were followed up consecutively after initial examination and primary treatment was done. Further follow-up visits were decided on the case basis depending on the visual acuity, slit lamp examination, staining, and disease severity. The aim of this study is to investigate the association between changes in cornea and various systemic diseases. Relevant personal and family history was taken about the systemic illnesses. Visual acuity unaided and aided with pinhole was taken. Anterior segment examination was first done in diffuse light examination and then under high magnification of slit lamp examination. Similar results were obtained in the following studies: Asif et al., Klassen, JLJ et al., and Jacqueline et al. These are the following diseases I studied. Autoimmune diseases included rheumatoid arthritis and systemic lupus erythematosus. Infectious diseases included tuberculosis and herpes simplex. Endocrine disorders were thyroid ophthalmopathy. Inherited disorders had Down syndrome, Marfan syndrome, and Ehlers-Danlos syndrome, and Wilson's disease was included in metabolic disorder. Results obtained was 86% population showed involvement of cornea in studied systemic illness, and 14% population showed cornea was not involved. Among the studied population, 70% people experienced dry eye symptoms, 10% had keratitis, 3% were presented with keratoconus, KPs, and keratinization, 2% had some form of corneal opacity, and 1% people showed corneal involvement in terms of KF ring. Conclusion showed, my study showed corneal involvement has been observed in number of systemic diseases. Systemic diseases may affect entire ocular surface. Corneal problems are seen in genetic, infectious, immune, and metabolic and endocrine disorders. Giving immediate, appropriate, systemic, and local management of various diseases may help patients to decrease the rate and severity of corneal involvement and hence help them to prolong the adverse effect of the related systemic disease.
Thank you. May I request the next presenter, Dr. Apurva Bagla? And Dr. Parul, please be ready.
Good morning, everyone. My topic for presentation is the case of keratoconus and its association with allergic conjunctivitis on a pentacam's perspective. Introduction. Keratoconus is a bilateral, asymmetric, progressive corneal disease characterized by progressive thinning and increased curvature. VKC, which coincides with keratoconus, can significantly induce progression and deterioration of keratoconus. Symptoms include eye rubbing, hyperemia, tearing, and photophobia. In the severe form, the cornea might be affected as a result of mechanical injury promoted by the rough surface of macropapillae, constant eye rubbing, and inflammatory mediators. Case details. A patient, a 17-year-old male engineering student, resident of Sonbhadra, came to our OPD with a complaint of gradual, progressive, severe diminution of vision in right eye more than left eye for 2 years, with a history of frequent change of glasses, history of frequent eye rubbing and itching in both eyes for 3 years, mostly in summers. On ocular examination, following findings were noticed. Vision 4/60 in the right eye, 6/24 in the left eye. Vision with pinhole, 6/18 in the right eye, 6/9 in the left eye. Vision with glass, 6/36 in the right eye and 6/9 in the left eye. On retinoscopy, scissoring reflex was present in both the eyes. On refraction, -6 diopter cylindrical at 60 degree gave 6/9 partial vision in the right eye, and -4 diopter cylindrical at 120 degrees gave a vision of 6/6. On torchlight examination, Munson sign was present in both the eyes and Rizzuti sign was also present in both the eyes. On slit lamp examination, giant papilla were present in the upper eyelid. Corneal Fleischer ring were present in both the eyes. Corneal thinning were present inferiorly. Vogue stria were present in right eye. Prominent corneal nerves were present in both the eyes, and oil droplet reflex was seen in direct ophthalmoscopy in both the eyes. These are the findings: Munson signs in both the eye, Rizzuti sign in both the eyes, Fleischer ring present in both the eyes, a corneal thinning seen inferiorly, and Vogue stria and prominent corneal nerves in the eyes. This is the pentacam of the right eye and pentacam of the left eye. These are the insignificant findings. K1 of the right eye was 52.3, K2 57.3, K max 54.7 diopters, Q value -1.51. Thinnest location of the right eye was 395 micrometers. Y coordinate of the thinnest location was -0.13. Inferior superior asymmetry in the right eye was 19.3 diopters. In the left eye, K1 was 44.4 diopters, K2 was 49.9 diopters, K max 46.9 diopters, Q value -0.81. Thinnest location 428 micrometers, Y coordinate of the thinnest location -0.35, and inferior superior asymmetry 11.2 diopters. My diagnosis was advanced keratoconus in the right eye and moderate in the left eye. Patient was given spectacles for regular use and advised 6 monthly follow-up. Patient was told to avoid eye rubbing and was treated for VKC. To conclude, ocular allergy has an important role in pathogenesis, disease progression, and treatment outcome in cases of keratoconus. Although a number of studies have proven this over the past decades, yet randomized controlled clinical trials on larger number of cases with longer follow-up
with longer follow-up is required. Control of inflammation and avoidance of eye rubbing may offer the best means to prevent keratoconus in these cases. A timely topographic assessment of patients with allergy may enable early detection. Thank you.
Thank you. Dr. Parul. So last presentation for the day, for this session.
Good morning. My presentation is comparison of topography parameter in ocular pathology and normal eye. Corneal topography remain an indispensable tool for diagnosis, treating various corneal conditions, and skin plug image is one of the most commonly used technique. Series is the new device based on this principle. It consists of combination of one rotating skin field camera and a placido disc. And there is an absence of data with reference to factor that disrupt the topography of the cornea. This study aims to characterize this data and evaluate the factor that disrupt the surface topography. A hospital-based study was done. Patient of more than 12 years of age with various corneal conjunctival disorder was taken. Group A consists of 30 eyes with corneal ectasia. Group B, 30 eyes with unilateral nasal pterygium. Group C, 30 eyes with eyelid chelation. Age, male, and gender distribution was studied. All parameters included thickness minimum, CCT, Kmax, SIN-K2, ectasia index, high order aberration was studied. And for significant difference determination, one-way ANOVA was performed. Group A, which have all ectasia patients, show all parameter significant difference. And Group B, which have pterygium patient, only keratometry and aberrometry showed significant difference. And Group C, which has chelation patient, no patient shows significant difference. Our study showed there are significant difference in CCT and thickness minimum between ectatic eye and normal eye, which was consistent with the study of Moses suffered. And this study also present topographic reference value for a healthy population with an average value, which serve as an important reference for future comparative study. Serious topography are highly affecting in distinguishing between pathological and normal eye, and topographic data not affected by the size, site, or location of the chelation. Keratometry and aberrometry had the highest diagnostic power in distinguishing between pterygium and normal eye. And the parameter used for follow-up of ectatic eye may differ at different level of disease severity. And awareness of this situation may help in planning follow-up. World Keratoconus Day will be celebrated on 10th November for raising awareness for keratoconus. Thank you.
Thank you. I would like to thank everyone for your active participation in this session. Thank you.
Next, we will have the next session. Okay.